My name is Eric Marsh. I'm one of the orthopedic surgeons here in town. I work both here in the hospital as well as across the street over at the VOC, is where I see outpatients. And tonight I'm going to talk about joint replacement surgery, specifically two techniques that I feel pretty passionate about. The first is anterior approach hip replacement, and you can see I brought some props today. The table that we use for that anterior approach hip replacement. I'm also going to be doing, at the end of the talk, I'm going to talk for probably about an hour or so. I'm pretty long-winded, so it may turn into closer to an hour and 15 minutes to an hour and a half maybe. But I'm going to be talking for a while, doing the demonstration of the table, and then we'll have a question and answer session, and then I'm going to do a demonstration of the computer-navigated knee replacement for any of those of you who are interested in or are here for questions about knee replacement. I'll talk more in depth about how that computer navigation system works, why I use it, and then do a little demonstration with some of the tools that we have down here. So, without further ado, we'll see if I get my stuff out of the way. So, what I'm going to talk a little bit about is the anatomy of the hip joint and the knee joint. I'm going to talk about arthritis, what it is, what causes it. Maybe halfway down on the lights?
Yeah, we leave one of those up.
How's that?
That's good.
Good? Talk about arthritis, what it is. Talk a little bit about the non-operative treatment, and then go into some detail about joint replacement surgery. And then again, at the end, we're going to do a demonstration of computer-assisted knee replacement. And then one other thing, I'm reminded as I'm sitting here in the back row, one of my patients has graciously offered to come here and talk a little bit about his experience with the anterior approach hip replacement. And he'll talk, when I'm talking about hip replacement surgery, about his experience, both in a previous surgery that he had through a different approach, as well as his experience recently here within this past month or so with his anterior approach hip. So the anatomy of our joints, all of our joints are lined by articular cartilage. Articular cartilage is a very smooth surface that lines all of our joints, not only our knees and our hips, but our ankles and our toes and our fingers and our spine. And all of our joints have this articular cartilage. The great thing about articular cartilage is it has extraordinarily low friction. So it has less friction than anything we can make man-made. So if you took two pieces of ice and rubbed them together, that's very low friction. Articular cartilage has significantly less friction than that. Am I going in and out? Okay. Yeah. How's that? Yeah, better? Okay, just if I start being too loud or not loud enough, just don't hesitate to interrupt me, please. So the purpose of articular cartilage is to allow movement across the joint and to allow our joints to last us for as long as they do. Unfortunately, if it gets injured, it does not have the ability or the capacity to heal itself or repair itself. So once that articular cartilage is gone, it's gone for good, and there's no bringing it back, there's no regrowing it. There are some labs that actually grow articular cartilage. I get asked all the time about, can't you just grow cartilage or put, growth factors or something into my leg and make that cartilage regrow? And the short answer is no. The long answer is that process of that cartilage growing over the end of your bones is a very complicated process that we really don't understand. So as you're developing in your mom's belly, and then as you're growing, those cartilage cells are growing and dividing into the shape of your knee or your hip or your wrist or whatever it is. So if we take some cartilage and grow it in the lab, how do we know how to tell that cartilage how to grow to shape exactly how it needs to be in your body? And that's something that's extraordinarily complex that unfortunately, I don't know that we're anywhere near understanding how to make something like that happen. So, so that's the cartilage. How about the joints themselves? The knee is the biggest joint in the body. It's a hinge joint in between the femur, which is the thigh bone, and the tibia, which is the shin bone. There is an additional joint there in the knee underneath the kneecap or underneath the patella. And again, this joint is covered by articular cartilage. The other important structures in the knee are the tendons and the ligaments there. We've got your ACL, or your anterior cruciate ligament, and the posterior cruciate ligament there, what we call the collateral ligaments on the medial and the lateral side. We also have the meniscus, or the menisci. You've got a medial meniscus and a lateral meniscus, and those are little C-shaped discs or cushions that sit on top of the tibia to help provide cushion and to help make that shape a little bit deeper so the end of the femur or the thigh bone sits in there the way that we want it to. The hip is the second biggest joint. It's a ball and socket joint. So just like it's described, the top of the femur is a ball and it sits in the socket of what we call the acetabulum. Again, lined by articular cartilage. It has a cartilage disc around it. In the hip, we call it the labrum. And we're learning more about that. One of my partners, Dr. Lightheart, who also does a lot of joint replacement surgery, also does some hip arthroscopy, so operating on the hip through a scope for problems with that labrum or that cartilage rim. And again, multiple muscles and tendons and ligaments that support the joint as well as help it move. So what is arthritis? Arthritis basically, in simple terms, is basically the loss of that articular cartilage. And it can happen for many reasons. The most common reason is just general wear and tear, or what we call osteoarthritis, where over time that cartilage just gets worn out. So even though it is very smooth, it has very low friction, it can get worn out. And so that is the most common cause. There are also other things that can cause arthritis. Trauma can cause it. So if you have a broken bone and that fracture goes into the joint itself. Now, if I just take that off, because it's coming in and out. Can everybody hear me? I know somebody was worried about not being able to hear. Yes? Yes? Injuries or fractures can change the joint surface, make the joint surface not as smooth or not as regular. That can lead to arthritis. Inflammation, or what we call inflammatory arthritis, the most common type of that is rheumatoid arthritis that most of you have probably heard of, but there are many, many other types of inflammatory arthritis where basically there is inflammation within that joint that attacks the cartilage, and that cartilage gets worn away. That can cause it. And then I'm going to talk a little bit about, more so with the knees, but an abnormal alignment or abnormal development of the bones. So in the hip, something that we call hip dysplasia, you may have had it or know kids who have had it, where the hip socket doesn't form deep enough. That can cause arthritis. Or abnormal development of the lower part of the leg. So somebody who's really bow-legged or somebody who's very knock-kneed ends up putting more pressure or stress on one part of the knee or the other. And again, we'll talk a little bit more about that when we're talking about knee replacement surgery. But that can predispose people to developing arthritis. What are the symptoms? The most common symptom, or the most important symptom, is pain. Very often it is kind of what we call startup pain. So when you first get up, when you first stand up, it's sore and it's stiff and it aches, and it takes some time to get ready for that first step, and it takes some time to loosen things up. And then often it will get better, but then often it will get worse if you do too much. So it's pain with activity. It can also be pain at night. So that's something that can obviously be very bothersome to people. If it's pain that's interfering with your ability to sleep, you're tired all the time, your joints hurting all the time, that can have a pretty significant impact on your quality of life. Other symptoms, I mentioned it a little bit, stiffness in the hip. A lot of people will become stiff enough that they have a hard time getting their socks and shoes on. They have a hard time, trimming their toenails and reaching their feet because their hip becomes so stiff. In knees become stiff too. You lose your flexion, you lose your ability to bend your knee, and very often you lose your ability to straighten your knee all the way out. So stiffness can be a big factor or a big symptom. A lot of times these arthritic joints will make noise. They'll grind, they'll pop, they'll crack. That can often be disconcerting to whoever it is whose joint is making that noise. As an orthopedist, the noise itself is not concerning unless the noise is associated with pain. If that crack or if that clunk is very painful, well, that tells me that you're probably actually hearing the arthritis or the bones rubbing. But most of the pops and the clicks and the snaps that we hear are from the tendons and the ligaments around those joints. And when the joint is inflamed or swollen from the arthritis, those tendons and ligaments are snapping or moving around those bones, causing that noise. So even though noise is often associated with arthritis, the noise isn't necessarily harmful or bad for you, but it certainly can be, again, disconcerting. Swelling, we see that more so in the knee than with the hip, just because the knee is a lot more superficial. You can see the swelling. You can't really see the swelling in the hip unless you are in there surgically, in which case I see somebody's hip being swollen once I get in there. But knees can be big and swollen and puffy, and that can contribute to some of that stiffness or tightness that people feel. And then some people will get a sense of instability or giving way. And I talk a lot to people about this symptom, that in general there are kind of two simple ways to think about instability of a joint. One is a mechanical instability. So the football player who tears their ACL, their knee is mechanically unstable. That ligament is no longer there to prevent the tibia and the femur from sliding against each other. So no matter what they do, that knee is going to be unstable. A kind of a functional instability is what most people with arthritis get. And the way I describe it to folks is it's what we call a pain avoidance reflex. And the easiest way to think about that is if you put your hand on a hot stove, you pull it off before you even feel the heat and before you feel the pain. That is a protective reflex that your body has. Well, in your legs, that protective reflex, if you step just the wrong way and you tweak your hip or your knee in such a way that is going to really hurt because of that arthritis, that reflex, you're standing just on that leg and you move it just the wrong way, the reflex makes your muscles relax. So if you're standing on that leg about to take another step and your muscle relaxes, what happens? Your knee buckles and it gives. Now, fortunately, you also have a reflex that doesn't want you to fall, so the majority of the time, that reflex will then kick in and you kind of catch yourself, but you have that sense of instability, and that is very often from what we call that pain avoidance reflex. What else can cause knee pain? Arthritis isn't the only thing, obviously, that I see people for. One of the most common things that we see people for is a torn meniscus. So that little C-shaped disc, that cartilage disc, can get a tear in it. Sometimes people with arthritis in their hip or a problem in their hip can come to me with knee pain. That's what we call referred pain. And the way that works basically is the nerve from your knee that is transmitting that signal up to your brain that tells your brain that your knee hurts, at some point in that pathway, the signal gets a little bit crossed and it goes to the part of your brain that your brain thinks it's, I'm sorry, I'm saying that backwards because I'm talking about referred pain from the hip. So the signal is coming from the hip, but your brain, it goes to the part of your brain that's for your knee. And so your brain thinks, ow, my knee hurts, but it's really coming from the hip. And I have actually done hip replacement surgery on someone who came to me for knee pain. And they say, my hip doesn't hurt at all, my knee hurts. Well, when I look at them and examine them, it turns out when I move their hip, they say, ow, my knee hurts. And then we'll figure it out, we'll do some other tests, and then I verify that the reason your knee hurts is referred pain and it's because of your hip arthritis. We do a hip replacement, lo and behold, they have no more knee pain. So that is, it's certainly not common, but it is not completely unheard of or unusual. The other very common thing that we'll see people with for knee pain is tendonitis or bursitis, inflammation of those tendons and the ligaments and the things around the knee joint can produce knee pain. So the way I figure that out, we'll show you in a little bit, is with X-rays and physical exam to try to determine what is actually causing that knee pain. Hip pain can be kind of challenging too. Probably, if not the most common thing that I see people for, one of the top, probably 2 or 3, is bursitis of the hip. So somebody comes in to see me and their hip's killing them and they can't walk, they can't sleep, it hurts to go up and down stairs, it hurts to sit down and stand up. The pain's right on the side, they can't sleep on their side because it's driving them crazy. Well, fortunately for them, the majority of the time that is bursitis. That is inflammation of this bursa right here, this greater trochanteric bursa on the side of the hip, and that's going to get better with a cortisone shot and some physical therapy and some exercise. But that is a very common reason of people having hip pain and coming to see me that doesn't need anything other than just some time and exercise and physical therapy to get these muscles strengthened up. The other thing that can mimic hip pain is arthritis in the spine. So similar to that referred pain in the knee, if the nerve that's going to your hip is getting pinched or squeezed in your back because you have arthritis in your back, your brain doesn't know where that nerve is getting irritated. It could be getting irritated in the back, or it could be getting irritated, in the hip itself, and that can very often mimic hip pain. And so I will not unusually see somebody who comes in to see me for hip pain. It turns out in their back, and it's coming from their back, and so I'll send them down the hallway to my partner, Dr. Zmerko, who's our spine surgeon, and he very often will see somebody with low back pain that's actually coming from their hip, and he'll send them down to see me because it's coming from their hip. So these things can all mimic each other. And how do we tell? How do we figure out what it is that's causing it? Well, it's going to be number one, listening to you and listening to you describe your symptoms and when you get them and how you get them. And there are certain things that make us get a sense of what's causing it and where it's coming from. But then the physical exam, moving the knee, moving the hip, checking the pulses, checking the range of motion, the strength, and all those things. And that's going to help us figure out where this pain is coming from and what's causing it. And then probably the clearest way to tell if somebody has arthritis is with an X-ray. So these aren't projecting terribly well, probably projecting a little bit better over on this one. So I apologize to you guys way over here. But if you can see this first picture, that's a pretty normal looking knee. There's the top of the tibia there and the end of the femur. And the gap in between those is where that cartilage is. So on the X-ray, cartilage doesn't show up. The bone shows up, but not the cartilage. And you want to see a nice big space there, as opposed to this knee right here, where the femur and the tibia right there are bone on bone. That cartilage is all gone. The bones are touching each other. That's arthritis there. Similar for the hips. This one here is the normal hip with good space in between that ball and the socket. And then this one over here where the cartilage is completely gone. I have this here just for completeness. Very often someone will come to me with X-rays. We will almost always repeat X-rays in our office for someone who has arthritis bad enough that needs surgery, because now all of our X-rays are digital. They're on our computer. And most X-rays that people come in with are digital as well. The difficulty with digital X-rays is you can shrink them and enlarge them as much as you want. So it's very difficult to tell what the true size of those things are. So when we take our X-rays preoperatively for somebody who needs a joint replacement, we actually put a little metal ball, a 1-inch, it looks like a 1-inch ball bearing basically, on that X-ray so that we know what the magnification is. And then I have a computer program that allows me to basically kind of what we call template or check to see what size your bones are and what size implants I'm going to be planning on using in the operating room. So we use that kind of technology and repeat X-rays quite a bit. So don't be surprised if you come seeing your doctor with X-rays that they may want to repeat them. The other thing that people always ask about is, do I need an MRI? Is the MRI going to tell us anything? Well, the MRI is very, very good for looking at the soft tissues, the ligaments, the tendons, the meniscus cartilage. But the MRI is very expensive. And for someone who has an X-ray that looks like this, that's completely bone on bone, the MRI is not going to give me any more information than the X-ray does, which costs about 1/10 as much. So very rarely in arthritis do we get MRIs, although we do sometimes. But most of the time, just these plain X-rays will do the trick. So non-operative treatment of arthritis. What are we trying to do? Well, I already talked earlier that once that arthritis is gone, we can't make it grow back. We can't make it come back. So the treatment for arthritis is aimed at relieving the pain and relieving the symptoms. And one of the most important things to remember is that arthritis is not bad for you. I tell people all the time, 10 times a day, well, arthritis is not cancer or a stroke or a heart attack or diabetes or pneumonia or any of those bad things that, if I were a cardiologist and I said, well, if you don't do X, Y, and Z, you might have a heart attack and die. Well, you're not going to have a heart attack and die from arthritis, but it might hurt like crazy. And so the treatment is not aimed at curing the problem, because if you have if you have an X-ray that looks like that one, but it doesn't hurt you, doesn't matter. It's not going to cause you any trouble. You can go on living like that with a horrible looking X-ray as long as it doesn't hurt. But if we can make it feel better, if it is hurting, we want to make it feel better. And so what are the things that we can do for you to try to make that feel better? Activity modification is one of the things. If somebody came in and told me, well, doc, it doesn't hurt except for if I go out and run 10 miles, I'll say, well, run 5 miles and then ride your bike for a half hour, or, find things that aren't going to make it hurt. But when somebody says, I can't sleep through the night because it hurts so bad, well, you can't modify that activity. You can't, if it hurts just going to the grocery store, there's only so much that activity modification can do. But that's the easiest one. There's no risk in modifying activities that cause pain. And so the treatment, we kind of go from the least invasive or the least risky to the most risky. So that first one, activity modification. Weight loss is the second one. So somebody who is a big, heavy person, will tell them if you can take some weight off, it will absolutely take pressure off of that joint. That being said, I do joint replacements all the time on skinny people. You're going to see one of them come up here in a little bit and talk about his hip replacement. Just being overweight doesn't cause arthritis, and losing weight won't make the arthritis go away. You can still have arthritis. But if you are overweight and you're able to lose weight, very often you will have less pain because there is less stress on that joint. But it won't make it go away. But we do encourage folks to try to lose weight when appropriate. Occasionally, we'll put folks in braces, so more so for the knee than the hip. If your knee is really bow-legged or really knock-kneed, again, we'll talk a little bit more about that later, but if your knee is really bow-legged or really knock-kneed, sometimes a brace that can support it and help straighten it out a little bit can make some of those symptoms feel better. The braces can tend to be cumbersome, so they don't work for everybody, but that's certainly an option. Assistive devices, basically that means using a cane or a walker. If using a cane or a walking stick when you're out walking makes that pain go away, certainly a lot easier to grab that cane on the way out the door than it is to have a big surgery. So again, very low risk with these things. Physical therapy and exercise. Very often, people with arthritis will lose some of their muscle strength because they are avoiding activity because that activity hurts. We have some pretty good data, more so in the knees than in the hips, but pretty good data that if you are able to strengthen up your quadriceps muscles, you will have less symptoms or less pain from the arthritis. So trying some physical therapy is often a worthwhile thing. That being said, those of you who have arthritis know a lot of times the more you do, the more it hurts, and so that physical therapy is a balance. And very often we have a difficult time getting people active enough with their physical therapy to make any significant functional gains in their strength without it making their knee hurt too much or their hip hurt too much. So it's something that we try, not necessarily formal physical therapy, although sometimes, but a home exercise program will give folks some exercises to try and see if that helps at all. The next thing that we'll try is medications. So now we're going into things that can potentially have side effects. So the anti-inflammatories, the Advil, Aleve, Motrin, those sorts of things, very helpful. Very often will help relieve some of that pain. But taken in too long or too high of doses, and especially in people who have other medical problems, whether it's diabetes or high blood pressure, they can cause unwanted complications. Ulcers in the stomach can make your blood pressure medications not work quite as well, and so affect your kidneys and things like that. Tylenol or acetaminophen tends to have fewer side effects. The big risk with Tylenol is if you take too much of it, it can affect your liver, but Tylenol is actually a very safe medication. For most folks, I think it tends to be a little bit less effective than the anti-inflammatories, but certainly worth trying at appropriate doses based on what the bottle tells you to take. Occasionally then we will give prescription medications, either prescription strength anti-inflammatories or painkillers. I try as much as possible to avoid any of the real potent painkillers or the narcotic pain medications for many reasons, but the biggest one is is that these medications, again, aren't going to fix the problem. They're not going to make the arthritis go away. So if I start giving somebody a narcotic pain medication, they are, over time, going to develop a tolerance to it, and it's going to become less effective. So in order to get that same amount of relief, they're going to need to take more of it. And the body builds up a natural tolerance to those narcotic pain medications. And so for something that's a chronic problem like this, those type of medications really are not, in my opinion, a great idea, because you end up trading one problem, which is your arthritis, for two, which is arthritis plus a dependency on those medications that then once, if you do come to have the surgery, can be very difficult to stop taking. So we try to avoid those things. Nutritional supplements, a lot of people try these with mixed success. I certainly think it's always reasonable to try, but the glucosamine or the chondroitin or the MSM or fish oil or any of those over-the-counter nutritional supplements, there is unfortunately very little scientific data to support any of those things. But what I tell all my patients is if you find one that makes your knee or your hip or your shoulder feel better, go for it. But if it doesn't make your knee or your hip or your shoulder feel better, don't keep wasting your money on it, because it's not going to make the cartilage grow back. It's not going to, cure the arthritis or prevent it from progressing. A little bit more invasive, the next step, if none of those things work, are injections. There are two types of injections. The first one are steroids or cortisone shots. Basically, the cortisone shot is a very potent anti-inflammatory. So it's like taking a whole bunch of Advil and putting it right into that knee joint. The risk of that is it is invasive. We are putting something in there. For those of you who are paying attention to the news this past fall, you probably heard about that pharmacy down in Massachusetts that had the contaminated cortisone that people were getting into their backs. That caused some horrendous complications, including several deaths from a cortisone shot. That just reinforces the fact that any time we're injecting something or doing something like that, it is not benign. Part of the reason that was such big news is that it's typically considered such a safe thing to do to give a cortisone shot. When I'm in the office, I'll often give 5, maybe even on a busy day, 10 cortisone injections for different things. And knock on wood, it is a very, very safe thing with an extraordinarily low complication rate. But that complication rate is not zero. So that's why we wait until we've tried some of these other things until we try the cortisone shots. The other thing that we will often try in people is this big fancy word called viscosupplementation. And basically what that is it's a protein called hyaluronic acid, which is a protein that occurs naturally in your body. It's in the joint fluid, and it's also part of your joint cartilage, and it helps basically give the joint fluid its thickness or its viscosity. And people who have arthritis have less hyaluronic acid in their joint fluid. And so the theory is we give you the shot of hyaluronic acid, it helps increase that viscosity or the thickness of the joint fluid, and maybe helps cushion or take some of the load off of the area that has arthritis. In most people who I give these shots to, it does work. The unfortunate thing is, the worse your arthritis is, the less likely it is to work. So all the studies that look at it, even the studies that were run by the companies that make these products, they all show that if you're completely bone on bone, if you don't have any cartilage left, the chance of those shots working to make your joint feel better, probably less than 50-50, and no better than a saline shot or a placebo. So the people that it works on are people who have arthritis but aren't quite ready for the surgery yet. They're not quite bone on bone. And those folks, I have very good results. I would say probably 75 to 80% of the time that I do these shots, in those people, they get pain relief. And the nice thing about these is you can return and have them redone in 6 months or so, have them done a couple times a year to keep the joint feeling well, to keep yourself up and active, and avoid having to do anything more invasive. And the next invasive thing that we're going to talk about is surgery. So that's our whole goal, is trying to treat as much as possible with avoiding surgery. So the surgical treatment is reserved for patients who have failed all of the non-operative measures. Patients, and the important thing, and how I say it to every one of my patients, is pain interfering with quality of life. Because that's what this treatment is all about. The treatment of the arthritis is about your quality of life. I've already said it, it's not about your health. It's not about something that's bad for you. It's about your quality of life. What makes you enjoy the things that you want to do? And if this pain is preventing you from doing those sorts of things, and we can't make that pain go away with any of those other non-operative things, then surgery is our last line of defense. I mentioned briefly arthroscopic surgery of the hip. Arthroscopic surgery, we do it much more often in the knee than the hip. Surgery through tiny little incisions where we use a camera and fiber optic light to look in there and to fix things and to trim out torn cartilage and to fix ACLs and all those sorts of things. It's a very good surgery. It works very well. Unfortunately, it does not help at all for someone with arthritis. So as nice as it is, the fact that you can come in and leave surgery the same day, tiny little incisions, quick recovery, it's not going to make your knee arthritis or your hip arthritis feel any better. So that's not the option. What is the option, the surgical option? If it's your knee, it's a knee replacement. And so what do? We trim away the arthritic surface of that knee joint, the end of the thigh bone or the end of the femur, the under surface of the kneecap and the top of the tibia are cut away. They're replaced with metal and plastic that is held in place with what we call bone glue or bone cement. And for the most part, we let your tendons and your ligaments and those things stay there. The only one that we cut out is your anterior cruciate ligament every time. Sometimes we will also cut out what's called the posterior cruciate ligament. I've got another slide that'll talk about that. But a lot of people are a little bit surprised that when they see the model and they see what it looks like, when they think of a knee replacement, they think we just cut the bone off here, cut the bone off there, and replace everything in between. Well, what we do is we basically shape the end of the thigh bone, taking as little bone as possible, and we take just enough bone that when we put that piece on there, it fits right where your bone and cartilage used to be. We take a little bit more bone off the top of the tibia or the top of the shin bone and hollow it out a little bit so this piece fits right in there, and then there's a piece of plastic that snaps in between, and that's your knee joint. But the tendons and the ligaments on the side and in the back and the kneecap in the front, those are all still yours. So that's what that knee replacement looks like. Yes?
When you put the knee replacement in, is that individualized to each person? Like,
Yeah.
Is that knee replacement made for each individual? It's not like one size fits all.
Correct. So for the, I'll repeat the question so that the people watching the video can hear it. The question is, are the knee replacements one size fits all, or is there different sizes for every person? And the answer is it is all individualized. Now there are some companies that make custom implants that are theoretically just for your specific knee or my knee. The vast majority, I would say probably 98 or 99% of the joint replacements that are put in are not custom made, but the company that I use, the sizes, there's a size 1, 2, 2.5, 3, 4, 4 narrow, 5, and 6. So there's different sizes for the thigh bone and different sizes for the shin bone. So while it's not 100% specific for you, the sizes are close enough that that you will have the right size for your knee. But very good question. There are multiple options. I just touched on this just a little bit with how we do it and kind of the different techniques that surgeons use, the different types of implants that are used, whether or not we cut away the posterior cruciate ligament, whether the piece of plastic snaps into the metal on the bottom or spins on the top, whether we put a little piece of plastic underneath the kneecap or not, whether we use that cement or bone glue to hold the piece in or not. And that choice, the vast majority of the time, is surgeon dependent. There are certain types or patterns of arthritis that dictate one or the other of some of these things, but for the most part, it is surgeon dependent. And for the most part, all of these options, the studies that look at these things on whether we cut the PCL out or keep it or resurface the patella or not, all of the studies that look at it and compare one to the other show that they're all pretty much equal. And so there's no one right way to do it where everybody sacrifices the PCL and does mobile bearing and resurfaces the patella and cements the components. There's not a right or wrong way because there are many ways to get a successful result with this. So one of the most important things in knee replacement, and one of the big reasons why I started using the computer navigation, is what we call the mechanical axis. And I've talked about this a little bit, the alignment of the legs. So what is the mechanical axis of the body? When you're standing up, the weight of your body goes from your body into your pelvis, into your hips, down to the ground, into your feet. And that's where that force, if you were a physics major in college and you looked at force and things like that, the force of your body weight is getting pulled straight down into the ground by gravity. Okay, so the force through your legs, through each of your legs, is going from your hip down to the ground into your feet. So if you're really bow-legged, that force, gravity doesn't know you're bow-legged, gravity isn't going to follow your legs, gravity's still going to pull straight down. So if you're really bow-legged, like this guy right here, and we draw a straight line down from the center of his hip to the center of his ankle, you can see that green line is actually sitting all the way on the inside of his knee joint. So all of the stress of his body when he was standing on his left leg was going through that medial side of the knee joint, and none of that stress was going through the lateral side. And you can see here on his right leg, that stress was actually going a little bit lateral to the center. So he was a little bit bow-legged on one side and knock-kneed on the other side. But that is where his force was going. And so when you look at his X-ray, you can see that on this side, the arthritis was all on the medial side, and on that side, the arthritis was on the lateral side because of his mechanical alignment. So what we really want is we want our knee to be right in the middle of that straight line in between the hip and the ankle. And so one of the important things when we're doing a knee replacement surgery is I wouldn't want to leave his knee that bow-legged on this side and that knock-kneed on the other side once his knee replacement's in. We want to straighten that out and give him a neutral mechanical axis. One of the other things that we talk about with knee replacement surgery is what we call soft tissue balance. So again, if you look at this X-ray here, you can see on that medial side of the knee joint, the cartilage is completely gone. And if you think about the soft tissues around the knee that are not showing up on that X-ray, there's a ligament here on the medial side of the knee, what we call your medial collateral ligament. Now, back before this person had arthritis, there was a space, about a centimeter worth of cartilage in between those two bones. And as that cartilage wears away, that space gets shorter and shorter. And so that ligament that used to be stretched out a centimeter more has contracted or scarred down. So then if we were to go and trim those bones out and cut those bones in a way to put the metal and plastic parts in there, but we didn't do anything to that ligament that was really tight and snug on that medial side, well, that knee would still be crooked because that soft tissue, those ligaments and tendons on that medial side would still be too tight. So what we need to do, so here's how that shows. So if we have gone in and cut the bone on the end of the tibia and the end of the thigh bone and put something in there and spread it apart, you would see that that space, even if we cut those bones so that they would be perpendicular to that mechanical axis to make that leg nice and straight, the soft tissues are still too tight. So what we need to then go do is balance those soft tissues, is kind of loosen up these medial-sided tissues to allow that medial side to open up and to make that a nice rectangular space there so that when that person is standing up and they're nice and straight hip, knee, ankle, there is equal force being put across that whole knee joint. So that's what we call balancing the soft tissues. And now the other thing, and this is something, and I'm going to try to explain it as well as I can, this is something that took me probably through most of my residency to really understand thinking about this. But then what is very important to do, and what I think the computer helps me out a lot doing, so I'll demonstrate this at the end when I use the computer, is now we want this gap when the knee is straight or the knee is extended to balance or be equal with this gap when the knee is flexed. So what this top picture then shows is, so after we make that knee joint a rectangle with the leg straight, we will then bend the knee up. And so when we bend the knee up, the top of the tibia the top of the tibia moves around the end of the femur. So the top of the tibia needs to be square or balanced with the end of the femur, but then we bend the knee 90 degrees. And so now the top of the tibia needs to be square or balanced with the back of the femur. So it needs to be square here, but then it also needs to be square with the back of the femur. And so this is one of the kind of the standard cutting jigs that we would use to trim the bone off the top and the bottom, or the front and the back of the femur. But we want that to be a rectangle as well. So how do we make that a rectangle? If we've already loosened up the ligaments, the way to make this a rectangle is to rotate this tool. So we rotate it that way to make this side a little bit narrower and that side a little bit wider. And then we've got a rectangular space in the back. So now when the knee is bent, it's going to be equally balanced, so it's not going to be loose side to side. And then what we need to do is we need to make sure that this rectangle is the same size as this rectangle. Because if the space when the knee is straight is this big, and when the knee is bent is that big, when you're going down the stairs and your knee's bent, it's going to be slopping all over the place, and you're not going to be real happy with your knee joint. So what we need to do is we need to make both of those rectangular and equal to each other. And there are many ways to do that, and this is actually from the technique guide for the implant that I use, where it talks about steps 1, 2, 3, and 4 of how to do that and how to make it equal and how to balance it, and what to do if this one's bigger than that one, and what to do if they're both the same size but they're both just too tight and you can't get the plastic in, or if they're both too loose. And so there are all sorts of different ways that those can be unequal, and there are ways to balance them out and fix them. But the great thing about the computer, and as I'm going to show it to you in a little bit, is that computer helps me measure those spaces before I've even cut the bones. And it allows me to cut the bones exactly where I need to make those things equal and balanced. And it's neat technology, and I think it makes my ability to make these rectangles rectangular and equal predictably. It makes my job a lot easier in doing that. So this is why do we do computer navigation? Well, I just talked about that soft tissue balance. That's a very complex thing. One of the things about computer navigation is there aren't any studies that show that it makes knees any better. In long-term studies, is it going to make the knee last longer? Is it going to make it better? We can't prove that because, as you can imagine, or maybe you can't imagine, and if you can't imagine how to do it, you can let me know. But trying to design a study or a scientific study to measure these distances in somebody's body once the implants are already in and they're sewn up and they've recovered and strengthened up, because it's so complex to be able to look at those things and measure and see, are they really equal? Are they as balanced as we think they are? And is patient A better, worse, or the same than patient B, regardless of how it was done? It's extraordinarily complex. So nobody has ever shown that computer navigation does this better. What I can say is my sense, in having done a whole bunch of them the standard way when I was in residency across the river over at Dartmouth, and having done a whole bunch of them with the computer, I'm much more confident when I leave the operating room every time that that is equal and balanced, but I can't prove it to you. But I'm pretty passionate about that. So that's one of the things. So it improves flexion and extension gap balance. The other reason, and I think the reason that most people got into computer navigation, and the reason that I probably started doing it and wanted to learn how to do it, was in order to restore that mechanical axis. Because what the computer has been shown to do over and over in many studies is it improves our ability to make that leg straight and to make those cuts exactly where we think we're making those cuts. And it's going to reduce what we call the number of outliers. So the number of people whose X-rays are not within about a 3-degree plus or minus of a neutral mechanical axis. Because there are studies that show that knee joints that are put in not in a neutral mechanical axis, more than 3 degrees off one way or the other, have a higher risk of early failure. And that, you know, that's pretty intuitive. If that knee, and I'm not going to keep flipping back and forth, but if that knee that was really bow-legged, if I put these parts in really bow-legged, well, that medial side of that plastic is going to wear out sooner than if you make it even so that stress or that force is getting distributed across the whole joint. And so there are many studies that confirm that computer navigation makes the overall alignment better. And the way that it does that, it doesn't make everybody perfect, and I'm not going to tell you that every single one of my X-rays is absolutely perfect where that line goes right through the exact middle of the knee every time, but it's pretty close. 98 or 99% of the time, it's within, you know, a couple degrees. Very, very rarely do I have one where either something happened with the computer or the patient had some abnormal anatomy or something happens that it's not as good as I want it to be. It's not within that 3 degrees. But there are many studies that show that the standard ways, even in high volume places, 20, 30, even in some studies, 40% of replacements are outside of that 3-degree range where we want them to be. And these are studies that are published by the guys who publish studies on joint replacement, who do lots and lots of them. So that was my main reason for doing it. But I think the thing that I think it helps me the most out now with, though, is that soft tissue balance. The reason that many people don't do it are a couple. Number one is it adds time to the procedure. And especially somebody who has done a lot of knee replacements without using the computer is going to be able to do them a lot quicker and a lot faster without using the computer software. Now, there's two kind of things that make that tough for them to switch. Number one is there are studies that show that the longer you're in the operating room, the higher your risk of complication and the higher your risk of infection. So if you can do a knee replacement in 45 minutes, and it's going to take you an hour and 15 minutes to do it with the computer, well, you know, how much are you helping those folks if you do have a higher infection rate? The second thing is there are a lot of people who need joint replacements, and if you can do it in 45 minutes and you can do 5 of them a day as opposed to doing an hour and 15 and only do 3 of them a day, you know, do you have enough time to be able to do that? Well, fortunately, I've now done enough of them that I can say I'm certain I'm doing them faster with the computer than I would the old-fashioned way because I've now done 500 or so with them. And so you learn how to do it as efficiently as possible. It's not a race. We're not trying to do it as fast as we can, but we don't want to dilly-dally either because, like I said, the longer you're in the operating room, the higher your risk of complications. So we try to be as efficient as possible. It does add cost. This machine and the software cost, I think, in excess of $100,000. Now, in the grand scheme of things, in our hospital budget of $200 million, $100,000 isn't a huge amount, but still $100,000. And so in somebody who's not doing a lot of knee replacements or someone who's not sure that they're going to continue to use it, it's a big expenditure to decide to do. So those are some reasons that people choose not to do it. And the other reason that they choose not to do it is, again, there's no proven long-term benefit. I can't look at you and say that my knee is going to be better than somebody's or somebody else's because I'm using the computer. But I know that if I'm doing your knee, I'm going to put it in the best that I can using the computer. The other important thing to think about is it's computer-aided surgery, not computer-performed surgery. I'm still doing the whole thing. I'm putting I'm using the saw, I'm putting the implants in, I'm doing all those things. The computer's just making sure that I'm doing it in the right spot. So hip replacement, very similar. In the hip replacement, it is probably a little bit more how people expect it to be, where we cut that whole ball of the femur off, and then we hollow out the socket. We hollow out the thigh bone as well. So you have a piece that goes down into the thigh bone with a ball on the top, a piece of metal in the hip socket or in the acetabulum that has a liner in there, and then that becomes your new hip joint. Again, similar to the knee, and I'm going to kind of go quickly through these. I left all these slides in there so it can be in your handout so you can look at them if you want. But lots of options as far as what these things are made of, whether we use plastic, come on. Whether we use a metal ball or a ceramic ball or a plastic liner or a metal liner or a ceramic liner, and then whether we use cement to hold the parts in place or whether we do what we call a press fit and we have the bone grow into little nooks and crannies. Those are things that, again, similar to the knee replacement, are for the most part surgeon dependent. I think most surgeons in the U.S. are using what we call that press fit technique, where you have this roughened coating on the top of the implant, and the pores or the gaps in between the bits of metal on this are manufactured in such a way so that they encourage bone to grow in between the little nooks and crannies. And so there is actually kind of a biologic fixation to these parts that we use in hips much more often than we do in knees. The vast majority of knees, we use that cement or bone glue. So the anterior approach to hip replacement. This is something that I've been doing for coming on a year and a half. I started doing it in November of 2011. I have now done about 100. I think I just went over 100 anterior approach hip replacements over that time. What is it? Why is it something I feel, first of all, why did I want to do it? And why is it something I feel that it's important to talk about? I think the why I switched, I did, from my first 5 years here, I did several hundred hip replacement surgeries through a standard or a traditional, what we call the direct lateral approach. And the two standard approaches that most surgeons use for hip replacement are either the direct lateral or the posterior approach. And with both of those approaches to the hip joint, you have to cut through some muscle and detach some muscle from the bone, from the end of the femur, in order to get into the hip socket. And those procedures work very well. Overall, hip replacement surgery is one of the most predictable and successful medical interventions of any medical specialist, certainly of orthopedic surgeons. Hip replacement surgery works. It makes people's pain better, it improves their range of motion, it improves their quality of life. It lasts a long time. There is a very low complication rate. So the standard way of doing it works really, really well. So why change it? Well, I talk a lot to people, and I've got a slide coming up later, about minimally invasive surgery, or doing things minimally invasively. And the goal of minimally invasive surgery is to speed up recovery. And in lay terms, or in the press, minimally invasive surgery means doing surgery through a smaller incision. And my bias on that, and it probably comes from training across the river over at Dartmouth, and the surgeons that I trained with didn't really believe a whole lot in that minimally invasive surgery. And the reason that was is because these are surgeries that we're hoping to last 15 or 20 or 25 or 30 years. And in a surgery that's got that big of a time span, if you're using your walker for an additional week or 2 weeks or a month to make sure that you see everything that you want and see everything perfectly, to put everything in exactly how you want it, to give it the best chance of that long-lasting joint, well, that's an easy choice. You use your walker for an extra 2 weeks and you have your joint in there perfect that lasts longer. But what, in an orthopedist's opinion, minimally invasive is trying to do it not necessarily through the smallest incision, but with the least damage to the muscle and the soft tissues underneath the skin. And so if we can cause less damage underneath the skin and speed up that recovery somewhat, but still have good exposure and good visualization of exactly everything that you need to see to make sure everything is in there perfectly, well, to me, that's kind of the best of both worlds. And that is what this anterior approach provides. It is a minimally invasive approach because once that skin incision is made, muscles are pushed out of the way and moved out of the way, but they're not cut. They're not removed from the bone, or they're not taken off of the bone in order to get exposure into the hip joint. And so that allows us in the recovery to eliminate what we call hip precautions. So the standard way of doing a hip replacement, when you wake up from surgery, you've got a pillow in between your legs with Velcro wrapped around that keeps your legs out wide, and you can't bend past 90 degrees, and you can't do this and you can't do that. And with my approach that I used, I didn't let people do any strengthening exercises out to the side for the first 4 weeks or so to let those muscles that we had to cut through, we have to let those muscles heal up. Because if those muscles don't heal up, you can have weakness and you can have risk of dislocation. So this approach, because you don't have to let those muscles heal back to the bone, you don't need to protect them. And if you don't need to protect them, you can allow your patients to move and sit and roll and stand and exercise however they feel comfortable right from the start. And so how do we do it? Here's the table right here. And there are many ways to do it, but this is the way that I have been trained in doing it, and I think the way that makes the most sense is to use this special table. It's called the Hana Table. You can see it's kind of funny looking. It's not a big flat operating room table like most people have seen or you might expect an operating room table to look like. But basically how it works is the patient lies here on this part of the table, and this goes right in between their legs and the groin, and their feet are in these ski boot looking things. And so at the beginning of the case, we'll put the patient's foot in these ski boots, tighten them down, and attach them here. And the important things about this table, number one is there's nothing underneath here. This is all carbon fiber. So we can get an X-ray during the surgery to look at the pieces and the parts that we're putting in. The other important thing, or the other neat thing about it, is both of these leg pieces move individually. So we can then, during the surgery, when we need to change things, change positioning for exposure, we can move that leg wherever we need it. We can adjust it for different lengths of the leg. We can twist the foot. We can do all sorts of things to allow me to position the patient's leg the way that I need to in order to be able to see. And the tough thing about this anterior approach is to get that piece into the thigh bone or into the femur. So you can imagine if a patient is laying on their back. Let's see if I can do it with this. So here's a left hip. And if I'm laying flat on my back and I want to get something into that femur, what we need to do is extend the leg, kind of drop it down to the floor, but then lift that top part up, because I've got to get over the pelvis and over the belly and then down in there to get that piece into the femur. So the way we do it is, and you're glad you're asleep when this happens, but after we've trimmed the neck of the femur, taken that ball off, so now the only thing that's attaching your leg to your pelvis are the muscles, which can move and stretch, we actually put that all the way down on the ground. So you can't do that with your hip still in the socket, because it'd pop the hip out of the socket or break your hip. So we've already detached it there, and so now the leg is down. And then the real neat thing about this is it's got this little lift in this bracket here. And this little thing, and it moves pretty slowly, but I've got a little step that I can move that adjusts this bracket. And so what I do is I take this hook and I slide it right underneath the proximal part of the femur or the thigh bone. I lift your leg up with this, and then I bring the bracket up to where it needs to be, and then I let go. So I know I've lifted it up a safe amount to hold that thigh bone where it needs to be so that I can get over the front of the pelvis and down the thigh bone and put that part in there. And then I already mentioned that we can get X-rays. The cool thing about this procedure then is that once I put these parts in, and this is actually an intraoperative X-ray of a patient of mine, and that is a trial piece. That's a piece that's gone in there during the surgery to make sure that I've filled up that bone and I've got the right size. And then we have different lengths of this neck piece and then different sizes of the ball that sits on the top. I will get an X-ray of their non-operative hip and then an X-ray of their operative hip. And on this portable X-ray machine, it has a printer that prints those up for me. And then I'll put a new pair of gloves on over top of my surgical gloves and stand on the side of the operating room with the X-ray machine, and I will trace out lines on the pelvis. I'll trace out this one right here and that hole there, that right there, that line that goes up, and then I'll trace out the lines on the end of the femur. And then I'll do the same thing on that other picture. And I'll flip them over and lay them on top of each other, and then I'm able to tell, have I recreated the exact position of where that femur was in space relative to the pelvis before the surgery. Because one of the big risks of hip replacement surgery is we can make your leg longer or shorter. As I said, once we cut that ball off, the only thing attaching your femur to your pelvis are muscles, which are stretchy. And so if I put something longer than you came with in there, it'll fit. We can stretch you out and make it fit. You won't like it once you wake up and your leg's too long, but we can do it. And so the standard ways of doing it, we couldn't get an X-ray until after the surgery was over because you were laying on your side on a standard OR table where you couldn't get an X-ray in there. And so we would measure things and we would check how hard it was to pull on your leg and how hard it was to pop the hip back in the socket, and we'd use those things to get a sense of if we were getting your length right. And we would do that templating like I talked about before, so you would know kind of what size you expected to use. And that works really pretty doggone well. But that gives me immediate feedback while you're still in the operating room and tells me, oh, nope, you need to be another ½ centimeter longer, or you're ½ centimeter too long, we need to use the next size smaller so that it's a little bit shorter. And it allows me to get it so that all of my post-op X-rays look just like this, where the leg length is right where it's supposed to be, what we call the offset, or the distance in between the pelvis and the femur side to side is right where it's supposed to be. And so by allowing me to do it minimally invasively, but to confirm in the operating room that I'm putting it in exactly as perfectly as I want it to every time, it gives me the best of both worlds, so that I can do it minimally invasively without compromising long-term results or long-term function. So I think that was, must be too far away. Uh-oh. No. So I think that's probably a good time to give myself a little break and let Mr. Morgan come up and give some of his thoughts on the anterior approach. So if you'd like to come up, I'm going to give.
Very enlightening. I've been through the surgery, but never having seen the pictures outside of after the surgery, I went on to Google and did a little research. But I think if I were to say anything, now I've had surgery both ways. On my left hip, I had it the traditional way, where the cut went down the side right here. And with this anterior approach, the cut is literally this long right in this area. So significant difference right there, not that that makes any difference. But I think if nothing else, with this approach, the more traditional approach, you do have your muscles being torn off or cut in the surgery. So that is the downside as far as I can see. And I'll talk a minute about the recovery period. But after my surgery here a couple months ago, I went into physical therapy. I guess it was, what, 2 weeks? I guess the second week after surgery, I went in. And the physical therapist, my wife drove me in there, and he said, well, let me see you walk. So I walked, and he said, well, he said, I can see we got some work to do on the left hip. And my wife commented, well, she said, it was the right hip was operated on. So what I'm saying here is the left hip never, even though I went through physical therapy, those muscles were torn from the bone in that surgery and never really recovered. And I'm still in physical therapy, but I'm not in physical therapy for my right hip. I'm trying to see if I can bring some of those muscles back on the left side. Now, a couple of the advantages from my perspective. Now, I say I've had it done on this hip one way, and the newer approach is just a whole lot easier on the patient. For example, this surgery, I was probably on crutches for 3 weeks, good 3 weeks, and then I went to a cane. This surgery, I was on crutches for, I think, 4 days, on a single crutch for 1 day. I was walking on a cane. Within 6 days, I was walking a mile on the road easily within a week of surgery. The old way, it was weeks. One of the things that I found terribly frustrating with my first surgery is part of physical therapy. They said, okay, now you lie in your bed, and we want you to lift that leg raise, straight leg raise. Well, my goodness. It was weeks, 3-4 weeks, and I would try and try and try, and the damn leg just wouldn't move. So for the fun of it, I got home after this surgery here a couple months ago, and I said, I'm going to beat that. Well, 3 days after I got home, boom. No problem whatsoever. The lack of restrictions is, as you can probably tell, I'm a fairly active individual. I don't like being tied down. With the old surgery, I was being tied down. The new surgery, Eric came in and said, look, there are no restrictions. And I said, well, what do you mean no restrictions? And he said, you can do anything you want to do. I said, I don't want you to, I think, go back this way or something, but there's not the risk of hip dislocation, which there was. With the traditional surgery, you had to be careful. There were a lot of things you simply could not do. The other thing which he mentioned was medication. We try to treat people. And obviously, after you've had major surgery, you are on some narcotics, some heavy-duty stuff. The first surgery, I was on probably the heavy-duty narcotics for 5 days, I think, when I was coming out of surgery. I think this time, the surgery was on a Tuesday. I think by Thursday, maybe I had narcotic in the morning. I think for the next couple of days, I took Tylenol or high-strength Tylenol, and that was it. So I think, again, once you get off those high-powered drugs, you begin to feel better. Your bodily functions return to normal, which is nice. After the first surgery, I was having to get up and go to the bathroom 3 or 4 times a night for weeks. And I said, oh, this is awful. You know, trying to get up out of bed and go make yourself to the bathroom was terribly inconvenient. I think with this surgery, frankly, I don't think when I got home, I don't think I got up at night at all. So once you get off those narcotics, your bodily functions return to normal, which is a very nice thing. So I think that, I don't know if I've covered everything, but generally speaking.
Any questions?
How about bending over?
Bending over? I mean, like so? Yeah. Yeah, I mean, it's one of the things I'd like to, we have a little bit of a workout room, and I enjoy rowing. And after the first surgery, I was told, look, you're never going to row again. Well, maybe a year. After a year, you can get back and row because they don't want you to, dislocate. So again, with this surgery, there are no precautions. I was back rowing 4 weeks after surgery on an indoor rowing machine. So can I bend over? Yeah. Question back there. Yeah.
Why did you decide to have any surgery or do it all? You've been through the first procedures that we talked about here, or were you in a lot of pain, or what was your reason for deciding to have
Oh, well, we live a fairly active lifestyle, and it reached the point, oh, why did I decide to have the surgery? And I said, basically, we live a fairly active lifestyle. And last fall, we took a hiking trip, and oh man, you know, going up those mountains was really getting to be painful. Or coming down the mountains was painful. Walking, just going out and walking the dog was becoming a chore. So I walked in, saw Dr. Marsh, and he went through, well, here are your Xrays, and you can see here. I said, look, I know what it's all about. I know it's bone on bone. Do it. Sign me up. I mean, there wasn't, I didn't need a whole explanation. It was the pain that, and we like to live an active lifestyle. We don't like to sit in front of a television set 24/7. Anything else? Yes?
So what's your pain level now?
0. And that was interesting. Coming out of surgery, and I should point this out, 2 things about that. One, the pre-op, Patty Popovich is back here, basically does the education for how you get ready for surgery. There are exercises you do. And I think she told me just before the class tonight that they can tell, he can tell, those people who've done the exercises, and likewise after the surgery. So, you know, the preparation. Let me take your question again.
Your pain level now?
Yeah, pain level. So coming out of surgery, right away they said, what's your pain level? And fortunately, where there was, you know, I think part of it was the pre-op preparation, but also they do check with you, and I don't think I was ever, you know, I guess, I guess I get up to a 3 or 4. Basically I was a 0, 1 after surgery, and I said, you know, it's been about 8 hours. I think I better have a pill. Don't let it go too long. That's the only suggestion I would make. But in terms of the pain, and I have no pain at all right now. It's
so
wonderful.
The weather changing doesn't. The weather changed. Everything has no effect on. Give or take.
Does the weather, and you know, I think in all honesty I have to say, does the weather change how I feel? Yeah, but that's arthritis. I mean, I've got arthritis in the back. I mean, all the joints. So the answer is yes. I think the weather does have an impact. It doesn't affect what I do, though. Okay. Anything else? Yes.
Did it bother you?
This gentleman.
Which type of hip did you have?
I mean, what device?
Yes,
I don't know what device.
that one? Not the ceramic or the metal?
I can't tell you. What did you do? All I can tell you, I went back post-op. I went back in. I saw the X-ray, and I said, "Oh, you put a screw in there to keep the cup in place." He said, "Oh, yeah, we do. I do that." So I don't know what you put in.
I don't remember. I'm going to grab this to answer. Question was, what does he have? And so with this approach, everybody gets the same stem, what's called this Trilok stem. Because of the size and shape, it allows me to put it in through this incision in this approach. The decision of whether to use a metal ball or a ceramic ball or a metal liner or a ceramic liner or a plastic liner is really patient and age and activity dependent. So in general, for my younger patients, I will use a ceramic ball on a plastic liner, and in my older patients, I'll use a metal ball on a plastic liner.
Am I a younger patient or older patient?
Well, so,
Honesty,
yes. So my cutoff tends to be around 70, but it is 70-ish depending on activity level. So, but that is because the ceramic ball is a lot more expensive than the metal ball. There are no studies in people that say whether one will last longer or shorter than the other. So trying to be financially responsible and not necessarily putting in the most expensive implant in every single patient. I do make some judgments on who I think is probably going to benefit from it, who I think basically, to be blunt and about it, is, you know, whose life expectancy is long enough and activity level is enough that if we do that metal on the plastic, they may wear it out before they wear out and need to have more. And so those people, I'll try to give them a ceramic to hopefully, in theory, give them more time before that plastic wears off. But very rarely, and I had that quick slide, very rarely, and I can't remember the last time I did a metal ball on a metal liner. That's been a lot in the news about the downsides of that metal on metal. So it's probably been 4 or 5 years since I've done a metal on metal hip. Everybody gets a plastic liner, and it's just whether you have a metal ball or a ceramic ball. Any other questions?
Yeah. Before you had the operation, did that pain during the middle of the night, you couldn't lay on it or anything?
It was uncomfortable. It was uncomfortable. The question was, before the surgery, did I have pain at night when I lay on my side? And the answer was, yes, I did experience some pain on the, you know, when I tried to lay on my side.
Yeah.
Yep.
When you were turning over, did you have that pain?
When I was turning over, did I have that pain? Yes. Yep.
That was a loaded question, by the way.
I thought she was going to make another comment, which.
I will. One of the other things that I noticed as his mate was that intimacy was a lot easier second time around.
Okay.
On that note.
On that note. What else can I say?
So I'm glad you guys were able to get the experience from somebody who's been through it. I think one little caveat to what he said, when I say there are no restrictions, I would say there aren't any limitations on how you can move and use the hip. The only restrictions that I put on people after any type of joint replacement, whether it's a knee or a hip, is jogging for exercise is probably not a great idea because of the impact and the stress. So high impact activities are going to tend to wear these things out sooner. I tell people, think about it like a set of tires on your car. The more miles you put on it and the harder those miles are, the quicker it's going to wear out. But that being said, getting on a rowing machine or going for a walk or skiing or hiking or golfing, swimming, mountain biking, any of those things are fair game after the surgery. So let's see, we'll try to go through these last. Oh, I'm going backwards. It's going to make the talk a lot longer. So this is always an important slide to show you guys, and it helps to get to a couple of the questions were about, you know, how much pain did you have? Basically, what made you decide to eventually do it? And that decision is going to be different for everyone, whether it's pain at night or too much pain so that you can't get through the grocery store or too much pain that you can't enjoy hiking or golfing or skiing or working or whatever it is. That decision, when that pain is interfering with your quality of life enough, has to be balanced against this slide right here. What are the risks? So there's a risk of bleeding. There's a risk of infection. That's the one that I worry the most about. That's the one that I think most people probably hear the most about. Fortunately, here at Rutland Regional, our infection rate's very low. It's now on the computer now that Medicare has all the hospitals release all this information so you can compare, and what you're going to find if you look at it is that our numbers are as good or better than pretty much everybody else around. Now, from year to year, there are small enough numbers that 1 or 2 infections in one place, whether it's here or up at Fletcher Allen or Dartmouth, can kind of skew those numbers because it's a statistic that, but taken over the course of about 5 years, our infection rate for hips and knees are both right around 1%. National average tends to be 1.5% to 2%. So we are better than the national average for both hips and knees, but it's not 0, and we're working towards 0. But that's the biggest one that we worry about, but we're doing a pretty good job with that. There's a risk of injury to nerves and blood vessels. There is a risk. Some people do have persistent pain. Some people, either the pain that I thought was coming from their joint was coming from something else, or there is something going on despite that joint being in there that people can still have persistent pain. Very unlikely, very unusual, but can happen. You can still have stiffness, especially in knees. If somebody has a very stiff knee before the surgery that doesn't bend very well, they're going to have a very difficult time getting that range of motion after the surgery. So you can have stiffness. You can have a blood clot. You'll be on Coumadin for a month after the surgery. We talked about the implant can loosen up or wear out, so basically you have to have it redone, and that certainly can happen. Fracture can happen. You can see the shape of this piece that goes in on hip replacements looks a little bit like a wedge, and you saw it on that X-ray. It fits right in there into that top of the femur, and I'm smacking it pretty good in order to put it in there, and if we smack it too hard, it can crack the femur and break the bone, so there is a risk of fracture. Dislocation. So you can see here, that's a patient who had surgery by someone else, but I've helped take care of, who their hip popped out of the socket. That is always a risk. Risk is very small with the anterior approach, but it's not zero. It could always happen if you move just the wrong way. And leg length discrepancy. We talked about that with the hip replacement. Pretty going to be minimized quite a bit with this anterior approach using the X-ray machine. So what to expect? And how do you do it if you feel like you need it? Well, the first thing you're going to want to do is meet with an orthopedic surgeon. So here are my other two partners who also do joint replacement surgery, Dr. Boynton, who does knee replacement, and Dr. Lightheart, who does hip and knee replacement as well. And they're going to help you decide if it's right for you. And basically the decision is going to be based on all of what we talked about: your symptoms, your X-rays, your risks, how it's affecting your quality of life, and all the non-operative things that we may try in order to allow you to avoid surgery. Once you decide that you're going to do it, we mentioned Patty Popovich there in the back of the room. She's our nurse case manager for orthopedics. She does a joint replacement class. You're going to meet with her and several other patients who are getting their joint replaced. One of our preoperative nurses, one of our therapists, physical therapy for both classes, occupational therapy as well for hip replacement surgery, so that you know the do's and don'ts on how to do what you need to do when you get home, what you want to do before the surgery to get yourself in shape and get active. You're going to see your primary care doctor, who's going to check out your heart and lungs and your EKG and blood work and all those sorts of things. Infection prevention, I talked about this a little bit. Part of that class is you will get a Q-tip shoved into the back of your nose. And the reason we do that, and it sounds probably about as awful, or it feels probably about as awful as I made it sound, but we're looking to see if you have MRSA. That's that methicillin-resistant staph bacteria. The reason we check that is because people who have MRSA on their skin, if they were to get a joint infection, are more likely to have it with that MRSA bacteria, which makes us change our antibiotic choice as our prophylactic antibiotic that we give you before the surgery. So that's just part of our process to try to minimize our risk of infection. We were the first hospital in the state of Vermont to have a MRSA eradication program. I think a couple others have joined on now, but we've been doing it for 3 years. Yeah, and I think it's a very important step at doing our best to minimize that risk of infection. If you do have the surgery, everybody knows that the sun always shines here in Rutland, so you're going to arrive at, doesn't it? No? Okay. You're going to arrive at Rutland Regional on a beautiful sunny day, and you're going to go through the same day surgery. You're going to meet the anesthesiologist who's going to talk to you about different anesthesia options, and I'm flying through here, who's going to talk to you about how you're going to be kept comfortable during the surgery, either a general or a spinal, and either one is fine. You're going to get some medications. You're going to get that preoperative antibiotic. You're going to get your first dose of Coumadin, that blood thinner, the morning of surgery. I'm going to put my initials on your leg, your knee or your hip, or both. Not both knee and hip, but both hips or both knees if you're getting them both done at the same time. And that's one of the most important things to verify that everybody knows what joint you're getting done and where the surgery is supposed to be. So very important step. You'll go back into the operating room. You probably won't remember seeing anybody in these spacesuits, but that's another thing that we do, minimize the risk of infection. So the whole front of our body, rather than just a sterile gown, we've got a sterile hood over our face to minimize the risk of infection or contamination. You'll wake up and you'll go to the recovery room, and then you'll get upstairs to our surgical care unit. Very often the day of surgery, especially with hip replacement surgery, you'll get out of bed and walk. Do you remember, did you walk the day of surgery or not? That's right, because you were last case of the day. So depending on when your surgery is done and when you get back to your room, you may not, but especially if you're the first surgery of the day, most people with hip replacement surgery will actually walk up on the floor the day of their surgery. After surgery, we're going to check your labs, we're going to check your vital signs, we're going to keep an eye on everything. You'll start eating and drinking more on post-operative day 1. You'll work with our therapist, our physical therapist who does most of our inpatient total joint replacements, Janet there, and an occupational therapist is going to help you figure out getting in and out of bed, getting to and from the bathroom, up and down the stairs, in and out of the car, getting dressed, all those sorts of things that you're going to need to do. They'll help you and practice with you and make sure that you can do all those things. Very often now, with this anterior approach hip replacement, probably 50%, 60% of hip replacement surgeries go home on post-op day 1, somewhere around there, which is remarkably different than the standard approach. My first 5 years here, I think I had 2 patients leave on post-op day 1 after hip replacement surgery. Now it's half, at least, are leaving on the day after surgery. Knee replacements typically take 2 or 3 days. If you get both of them done at the same time, it's probably 3 to 4 days where you're here in the hospital. You will continue with therapy every day during your hospital stay. We'll continue to watch your blood counts and your vital signs and things like that.
Dr. Marsh,
Yes.
if you were thinking of doing double knee replacements, is it wiser to go to a rehab center after? And if so, if at home you have stairs, how long does it take before you can go home to where you need to get up and down the stairs?
Yeah. So the question is, if you have both knees done at the same time, can you go home? Do you go to rehab? How long is it going to take you to be able to do stairs and be independent at home? 2 or 3 years ago, my answer would have been a lot different. 2 or 3 years ago, probably 90% of bilateral knee replacement patients went to rehab. Reimbursement for rehab units through insurance companies and Medicare is shrinking and shrinking and shrinking because even though they're less expensive than the hospital, they're more expensive than getting taken care of with visiting nurses at home, and so they're making it tougher and tougher for us to get people into those places. And so more and more people are going home, and what we're seeing is they're doing pretty well even at home. So at this point, I would guess it's only about 25%, maybe at the most, of my bilateral knee replacement patients that are going to a rehab unit. I have had people leave as early as day 2 post-op from a bilateral total knee going home. And in order to go home, you've got to be able to do stairs. You've got to be able to safely get in and out of your house. You've got to be able to safely get to and from the bathroom. And so how long any individual person is going to stay is going to be dependent on how well they move around and what they need. And if you're not moving around well enough at 3 to 4 days post-op and you need rehab, we will absolutely get you there. But if you're moving around well enough and you can get in and out of the house and you're comfortable, then we'll get you home. And I think in general, most people are more comfortable at home. Now, the therapy is going to be different, and it is very important for people who go home, regardless if it's one knee or 2 or hips, that you do your exercises. One of the things that I always tell my patients, you can have the most beautiful looking X-rays in the world. I can do my part in the operating room perfectly, and if you don't do any physical therapy, you're going to hate your joint replacement because it's not going to move, it's going to be stiff, it's going to be sore, it's going to be painful. So the key for any of this, for a good outcome, is to do the exercises, regardless of if you're in your own bed or on your couch doing them, or if you're doing them with a physical therapist holding onto your hand. So long-winded answer to your question. If you need it, you can go, but we're finding more and more, most people can actually go straight home even with having both of them done at the same time.
And exercising, I have a girlfriend that had both knees done. She said that she wished that she knew more about the exercises she needed to do prior to both knees being done than after.
Yeah.
She said it would have made her rehab after easier. So what do you suggest for that?
So question is, She had a friend who had bilateral knee replacement and wished that she had had more instruction on exercises preoperatively to get ready. So Mr. Morgan touched on that. We talk about that at the joint replacement class. But basically, the important things are walk as much as you can, keep them moving as much as you can, and do strengthening exercises for your legs. And it's hard to say for everybody what to do because it depends on how much pain you're in and your strength and your range of motion. But easy things to do are straight leg raises. So when you're laying in bed, you just pick the leg up off the bed, hold it up there 6 inches off the bed for as long as you can hold it up, and then put it down, and then do your other leg. If that is too easy, you can do squats or lunges, you know, and thinking about proper mechanics and body mechanics for those things are important. But a lot of people with arthritic joints have trouble with that because getting down in that squat position puts a lot of stress on the knees. But those are some things to do. But the easiest things are just walking and straight leg raises. Yes?
I had an experience which turned out good, but I had a pain in my groin, but I went for quite a while and I went in, but it didn't show up on the X-ray.
Mm-hmm.
Or they looked at me and they probably thought, well, she's an old lady and we won't. So I went in again and it still didn't show. They told me this show up on the X-ray. And you happened to be in that night, and you sent me over for an MRI, and it showed up.
Yes.
Stress fracture or something.
Yes.
And you operated that night. Doctors generally don't at night. They wait
Yep.
until the next day or something.
Yep.
But you operated that night.
Yeah.
And they had me going. I was the next morning. They had me doing some rehab, and it wasn't hurting. And they had me going in a couple of days. I think I went home in a couple of days, and the visiting nurse came in. But I've been an active person all my life, but it was hard to convince them I had anything wrong with me.
Yeah. And so comment is about a patient of mine who had some negative X-rays but a lot of hip pain, and I did end up getting an MRI, which even though I said for most times arthritis doesn't need an MRI to diagnose it, she had something else going on that wasn't showing up on the X-ray that the MRI did pick up, and we were able to get her hip feeling better. And one of the most important things that she said, right after surgery, as soon as we fix whatever that problem is, we want to get you up and moving, because the longer you're in bed, the more you have risks of a lot of those complications like I talked about, blood clots, and I didn't put up there pneumonias and urinary tract infections and all those things. So the sooner we get you up and moving after the surgery, the lower the risk of complications. Yes?
Have there been advances in the knee replacement technique since the 11 years ago when you were a resident at Dartmouth and I had mine done?
Yeah.
Has it changed?
So the question is, have there been advances in the technique for knee replacement in the 11 years since she had her first knee replacement done? Yes and no. Now, I still use the implant that I learned how to use when I was over at Dartmouth because it is a very good implant with a long track record that works well. I think it's pretty likely at some point in the next year, the company that makes the implant that I use has a new version of it that has some things that I think are going to probably make it better. I have not started using it yet, but I probably will. Is that a reason to wait until I start using the new one? I don't think so, because I think this one that I've been using for the past 6 years and I used for 5 years at Dartmouth is pretty doggone good. And so I don't see a huge reason to rush into using necessarily the newest or the latest and greatest. But I think for me, the biggest thing that's changed since my training is using the computer and getting that balance correct, getting that alignment correct. So who is a candidate for this? Obviously, you have to have arthritis on your X-ray. We talked about it already. You need to have that pain. And the final decision really is up to you. Is that pain interfering with your quality of life enough that you're willing to accept those risks? What do you want to do to prepare? You want to do what you're all doing right now, is you want to learn as much as possible about the procedure so you understand what's going on. Don't be afraid to ask questions. Don't be afraid to call up your doctor and say, hey, I don't understand this or that, or why don't we do this, or why do we try that? You want to prepare yourself physically. We've talked about that a lot. You want to exercise preoperatively to maximize your ability to recover postoperatively. You want to think about how you're going to sleep when you get home. So if you have, you live in an old farmhouse and your bed's up on the 3rd floor and the stairways are this narrow and they're this steep, you may want to think about that before you walk back in the door postoperatively, and how in the heck am I going to get up there? So you want to have these things planned ahead of time. Expected outcomes, pain relief is the big one. What we want you to do is we want you to feel better. We want you to function more normally. The surgical pain, Mr. Morgan talked about that. Everybody's pain is going to be different, and there's a bell curve of where most people have pain and when most people stop using the walker and stop taking the pain medications. He certainly is on one side of that bell curve, and he's on the one side that you all want to be if you have that surgery, where you get better real quick. But not everybody gets better that quick, and that pain can last longer in some people. And so you just need to be patient with it and understand that the pain that you wake up with is surgical pain. It's no longer that arthritis pain, and that surgical pain will get better. Hopefully it gets better in days, but sometimes it's weeks, and sometimes, unfortunately, it's months. But it does get better. And then we want you to get back to your normal function. We want you to do the things that you want to do. We want you to do the things that make life worth living. So I already talked about all these things, but we want you to get back to that quality of life on the things that you really want to do and that you enjoy doing. Talked about maybe I didn't talk about this. How long will they last? I told you that I wanted them to last 20 years. The long-term studies show about 80% 20-year survival. That means about 20% of them don't last that long. So this is an X-ray of a patient whose knee I had to do a revision on. And if you look underneath that, kind of hard to tell on this picture, but underneath that tibial tray, the bone has kind of worn off. And that's an inflammatory response to some of those plastic particles that get worn off in there. And so some people do need to have it redone. But for the most part, we expect that these things are probably going to last 20 years or so. The studies that look at that are looking at joints that were put in back in the 80s in order to get 20-year survival data. We're looking at joints that were put in a long time ago. We do think that the technology is a little bit better. The plastic parts are a little bit better. The plastic is harder. The techniques and the way we put them in, we think, are better. So hopefully these numbers will get better over time. But 20 years ago, we weren't putting these in many 50-year-olds, and we weren't telling people, go do whatever the heck you want, because that's why we do it. They were telling people, don't get on your rowing machine for a month, and don't do this and don't do that. So hard to know how that increased activity and increased expectations that people have are going to offset the increased or the newer technology. Come on, there we go. Minimally invasive joint replacement, we already talked about that, so I'm going to skip that slide. Partial knee replacement, something that I do a little bit of. I probably do about 5 or so of them a year, as opposed to well over 100 full knee replacements. Basically, if you only have arthritis in one part of your knee, may make sense to only replace that little part and leave the rest of your knee there. But the majority of patients do have some arthritis in 2 or more parts, either on the inside as well as underneath the kneecap, or both on the inside and the outside. And so those folks aren't necessarily a candidate. But there are certainly some patients who are a candidate for this. Certainly happy to talk to you about that as an option, if that might be an option for you. Hip resurfacing is something that other people talk about. I mentioned earlier, hip replacement is one of the most successful and predictable and reproducible surgeries that we do. So trying to get too fancy and doing just this resurfacing, which is more similar to what we do with the knee, where instead of cutting the whole ball off the end of the femur, we just shape the femoral head and put a metal cap on there. In my mind, there's a lot of downsides to that. There is a not insignificant risk of having a femoral neck fracture below that because of how it sits on there. It is also, in order to do it, you have to do that metal on metal that I talked a little bit about, and there have been a lot of publications and a lot of concern about that metal on metal type bearing surface that, to me, make this not a great option. But certainly Some surgeons are still doing that. So at this point, I'll open it up to any more questions that you have. Anybody who is tired of listening to me talk, and that is an hour and 45 minutes, which is way longer than I said. So I apologize for that. But certainly feel free to stand, stretch, leave if you'd like to. But if you want to see a demonstration of the computer, we'll get that set up here in another 5-10 minutes. Yes?
Yeah, Doc, I'd just like to say that it's been 10 years for me on this knee. It's fantastic. Been 8 years on this knee, and I think in my hip, it's been 6 years. It was all done at VOC. So
Thank you very much.
I think the big thing is to be positive.
Yep.
You don't do your rehab, you're wasting time. You know, you have to do exactly what they tell you to do.
Yeah. So for the video, happy customer with 3 joint replacements from my partners who stressed the importance of doing your therapy and your exercise post-op. And I agree, that makes all the difference, all the difference. Yes?
Why do patients with a total knee have some pain in their tibial shaft?
Question, why do patients with a total knee have pain in their tibial shaft? Very difficult to answer, could be any number of things, probably depends some on the type of implant that was used. So certain types of implants can have a higher risk of that. Certainly a revision implant can have a higher risk of that. Hard to say. It's possible that the piece is actually loose and not sitting exactly where it should be. It could be tendonitis, it could be bursitis, it could be coming from the hip, it could be coming from the back, but hard to know specifically. Yes?
On pre-op, my knees are sort of shot at me,
Yeah.
as you very well know.
Yes.
You think, I mean, you mentioned like the leg raises and that sort of thing for exercise, but
Yeah.
it's like low impact things like exercise bicycle and to keep it moving?
Yes.
Is that what I'm
Yes, absolutely. So question, exercise pre-op for somebody with bad knees, low impact activity, and the answer is yes. So exercise bike, one of the best activities, and I should have mentioned it earlier, swimming. Somebody just whispered it. Yes. Swimming is the best exercise for somebody with arthritis because it's almost no impact. It allows you to work your cardio system, burn calories, lose weight, but get good strength. So walking, stationary bike, swimming, leg lifts. Yep. Yes, sir.
This presentation, is this something you do regularly? First time I heard about it, I saw it in the newspaper.
Yeah.
Is this something that goes on regularly or what?
So question is this type of thing something we do regularly? This is probably the 7th or 8th time I've done one of these. Oh, maybe even more than that. I probably do about 2 a year, one here in Rutland, and then I'll do one I've done one in Fairhaven and one in Manchester, Brandon, Ludlow. So I'll do one here and then one somewhere outside. And my partner, Dr. Lightheart, has one coming up in 2 or 3 weeks in Manchester. And then in the fall, he'll probably do one here. So we do these quite a bit. Yep. Yes?
How often do you do bilateral hip?
The question is, how often do I do bilateral hips? I did my 2nd one yesterday. I'm going to do my 3rd one next Monday and my 4th one in a month or something like that. I'm a big believer in bilateral knee replacement. I've been doing that ever since I got here. It's something I picked up in my training over at Dartmouth, so I do bilateral knee replacement an awful lot. One of the big advantages of this, and I didn't mention it, is because there are no restrictions, no precautions, you can do both hip replacements at the same time. You can imagine with the standard way, with the hip precautions, you can't bend past 90 degrees. If you have both your hips done at the same time and you can't bend past 90 degrees, you can't lean forward to sit up. You have to kind of push yourself up, which isn't a real comfortable way to get up for 6 weeks as you're maintaining those precautions. But so to answer how often do I do them, I really wanted to make sure I was comfortable and facile and kind of as quick as I needed to be in doing it through this anterior approach on just one before starting to do them on both sides, and then making sure it's the right patient, because one of the tougher patients for me to do this on is somebody with a really big muscular leg. So you can imagine a nice skinny guy like me, I don't have that much muscle in between the front of my thigh and my femur. But a big, 250-pound guy who's got a thigh that's this big, well, his muscle in the front of his thigh is going to be about this big instead of about, that big on an average person. So in order to get down there and move that muscle out of the way is physically harder. It takes longer. There's going to be more blood loss. So finding the right patient for the first couple times that I did these both, I thought was important. But the first one that I did, the patient went home on postoperative day number 1, which absolutely floored me that the day after surgery, having both of his hips done, he was feeling great and went home. The one I did yesterday is probably going to be with us for 2 or 3 more days. Well, 1 or 2 more days, at least until tomorrow. But she got up and walked today, and good pain control. And so it is certainly something that I will do in the right patient who needs it, and I think that's one of the advantages of this approach.
Both hips were equal, and the decision was made not to do bilateral hips.
Yes.
What's the spacing like for the 2 different surgeries?
Yeah. So question is, if you need both hips done, but you don't want to do them bilateral at the same time, or it's decided not to do them at the same time, what's the spacing? It really is more dependent on the patient and what they want to do, and if they want to have them both done as close together as possible, I'll do it about 3 weeks apart, which is close enough together that the recovery kind of piggybacks on itself, so you don't have a surgery and a full recovery and then 3 months later have another surgery and a full recovery and lose a lot more time. I try to do it relatively close together. As my patient was mentioning, by a week he was already off his crutches and off his cane, so at 3 weeks out, that hip that you had done first, knock on wood, is going to be pretty good. It's going to be pretty strong to be able to have you ready to get the other one done. Yep. Yeah.
Does age make a difference?
Does age make a difference in what?
On the hip operations?
So age, the difference that age makes is the older you are, you have a higher risk of medical complications. So somebody who's 50 and doesn't take any medications versus someone who's 90 and is on blood pressure medications and diabetes medications, their risk of having a heart attack or a stroke or a blood clot or those sorts of things are going to be higher. Yeah. But that being said, I have the oldest hip replacement patient I've done electively. I don't know if I've done any 90-year-olds. I know I've done it on an 89-year-old. And I know I've done hip fracture surgery on 90-year-olds. The oldest knee replacement patient that I did a knee replacement on was 94 at the time. The last time I saw her, she was 97. She had unfortunately fallen and broken a hip, and one of my partners took care of that, but I saw her after that. And her knee was still doing good. When I did her knee replacement, she was basically getting to the point where she was wheelchair bound. And so that was what allowed her to make that decision. Like I said, everybody's decision is different. And she had just, for 10 years before that, I'm too old to get my knee replaced, I'm too old, and she just lived with it to the point where all of a sudden she was really wheelchair bound. And so she didn't want to be wheelchair bound anymore, so we did her knee replacement when she was 94. So I've done a lot of knee replacement. I've done at least 5, if not maybe 10 knee replacement surgeries on people in their 90s. So there's no age cutoff. It's just all about that risk and benefit. Any other questions? Okay, so get up and stretch. For those of you who want to sneak out, feel free, absolutely. The computer demonstration it'll take about 5 minutes to get set up, and then it'll be about 10 or 15 minutes more of me blabbering on. Is how I use the computer and how it works and how I feel like it's going to help me restore that mechanical axis that we talked about, make that leg straight, as well as get that balance, that soft tissue balance in between flexion and extension. And so the way that I do it, and I'll turn this around real quick so you guys can see it, is here's a leg, and it is a left leg, and we put these pins into the thigh bone as well as into the shin bone that have these pieces attached to them. And these pieces, each of the pieces that the computer sees has 3 balls on it, and they're separated in a specific pattern that the computer is going to recognize. And the reason that they each have 3 spots is that for those of you who remember your geometry from high school, if you know one point in space, you can only define that point. If you know 2 points, you can define a line. If you know 3 points, you can define a plane. And if you can define a plane and you know those 3 spots, you can move it in any direction. And if you're smart enough or have a computer that can figure it out, you know exactly how that plane is moving in all 3 planes of motion, up, down, front, back, side to side. And so each of these things has 3 balls on it, separated differently so that the computer knows which one is which. So this piece is fixed to the femur. This piece is fixed to the tibia. And so what we kind of tell the computer is that those pieces are on a fixed spot relative to the femur. On a fixed spot relative to the bones. And when you look at the picture up on the screen, you can see the yellow one is shaped like a Y, and that kind of fuchsia one is shaped like a T. That T, as this computer is looking at it, it's got 2 infrared eyes, so it has binocular vision, so it knows depth. And if I block that infrared, you can see that those purple dots get blocked. So it can only see what it can see. So that's the tibia, and that's the femur. And then it can also see when I move the leg, you can see that those things are moving. And so that computer is calculating how those things are moving. And I can twist them, and you see that it follows all those movements. So it is able to tell how those things are moving. So the first step in the process is for me to help the computer create a model of this patient's leg, of their hip, their knee, and their ankle, so that the computer can calculate that mechanical axis, and then that model will help me get those gaps balanced. So we'll start out. And this, by the way, I want to thank Randy. Randy works for DePuy, who's the company who makes the joint replacements that I use. He or his partner are in the operating room helping out whenever we're doing any of our surgeries, they're not scrubbed into the surgery, but they're helping the nursing staff make sure that we have all the parts and pieces that we need. And then when I'm using this, they're helping run this computer for me because the computer is out of the sterile field, so they're helping push the buttons. So the first thing that we do is I move the leg around, and that little green bar on the bottom is calculating the center of the hip. So the way the computer did that is it could basically calculate the arc of the radius that hip was pivoting in, and it knows that the center of the hip is where that pivot is centered from. So now it knows that spot in the center of the hip. And now I'm going to use this thing. Again, it's got 3 dots with a little point on the end. So the computer knows where this point or tip is on the end in space. And I'm going to go through a bunch of spots on the knee, basically telling the computer this is at this specific point. So the first point, that femoral mechanical axis point. I'm going to give that computer all this information, and it is going to create which one's medial? It's going to create a model of this patient's knee. And we're going to loosen this up just a little bit. Yeah. So it's actually a little bit easier. Randy, can you lift it up a little bit higher? There you go. Believe it or not, this is actually easier in a person than it is on this plastic model. But you can see all those red dots that are going there. Those red dots are points in space that I'm telling it are right on the surface of this patient's femur. And so it's going to take all this information and create a model of the femur. And then it's going to give me a chance to, just skip that one, to verify that the model that it created is accurate. So you're going to be able to see in the bottom left-hand corner of the screen, it's going to, or the bottom right-hand corner of the screen, it's going to say distance to model. And so it is calculating how far away from the model that it created of the bone the tip of the pointer is. So when I hold it way out here, I'm 150 millimeters away from the bone. When I put it right on the bone, distance to model is 0 millimeters, a half a millimeter. And as I move it here, a half a millimeter, 1 millimeter. So the computer model that the computer generated is almost exactly where this person's bone really is, within a half a millimeter or a millimeter of being exactly right. So now I'm pretty confident that it knows where this person's femur is. So now we're going to do the same thing for the tibia. And so I showed it where the ankle was, because it needs that for the mechanical axis. And when you've done 500 of them, you know exactly what the order is of where you need to go. So that's why I'm able to kind of zoom through that. And that's why now, for me, timing-wise, it doesn't particularly take any longer for me to use the computer and do this information than somebody who's doing it the standard way. And so it's going to create a model again here that we'll get to verify. So again, distance to model is within a half millimeter, maybe a millimeter, which, you know, a millimeter is that much. So it's really a very accurate model. So then we will look at it. And can you back up so you can show the zoom out? Yeah. See that varus, where it says varus, and that's just a measure of the bow-leggedness. The patient that I did today was 6 degrees or 8 degrees. The X-ray that I showed you during my talk of that mechanical axis, that patient was in 14 degrees of varus, which on this I'm having a hard time even bending it far enough, but he was in 14 degrees of varus. He was like that. So we get a start, and go ahead and store that. We'll just pretend this person's in a lot of varus. We kind of save where the person started out with, and go ahead and hit next. Yeah. And now what the computer is going to do is it is going to tell me where I need to cut this person's bone in order to make that cut perpendicular to that mechanical axis, so that when those implants are in, we've created a neutral mechanical axis. And so this is the little piece that we use. This is the standard cutting block that we use when we're not using the computer, that clamps onto the outside of the leg and sits on the front of the tibia. And now we know, based on, you know, feeling the points of the ankle and where we set this and adjust this, we tend to have a pretty good sense of where that needs to be in order to make that cut perfect. But again, as I said, a large percentage of total joints are put in not exactly as perfect as we want them to be. So what the computer allows me to do is we use this little thing. We've got a fancy name for it. We call it flat foot, because it's flat on the bottom and we're not very creative. But this has a little piece that slides into the slot on that cutting block. And so that yellow line that you see is where the computer wants me to cut this person's bone. And not seeing the tibia, I'm in the way. The blue line is where I have the cutting block. And so I could have started out, you know, like that and been way off. And then so I've got to adjust it and move it so that that line is parallel and lying right over top of it. And then what I do is I hold this in place with a pin. So we'll get it close. And this is the part that's definitely a lot easier in the operating room than it is here. I've got to say, the first time that I did this at one of these talks, was probably one of the most nervous times I've had in front of people, because I didn't want to look like an idiot in front of people who I was trying to convince that I knew what I was doing. So this is now a lot easier. But so we put that in place, and then this is going to be really loud for a couple reasons. Number one is this is loud, and on this table it really vibrates a lot, so I apologize. This is going to be really loud. But then what I do is I cut this. So we cut that, and then the other really cool thing about this is the standard way we can have this positioned perfectly, but the saw blade, and it's usually pretty hot when we do that in the plastic, the saw blade's pretty flexible. So if the bone is really hard, despite the fact that it's going through here, it can actually skive off and not be cut perfectly, even if you put it on perfectly. So the computer allows me to verify the cut, and there you go. I'm showing a good example of why the computer helps, because then when I put that on there and I see how it made me make the cut, I say, well, you know what? I need to trim that up a little bit. And so you could see as I went through there, even though I went through the same slot, I took a little bit more of that plastic foam away. And so we'll see, you know, and that looks better. And now in the operating room, I would say, you know what, that's still not quite as good as I want it to be, and I'd make another cut. But for these purposes, we'll accept that. And then, so we'll store it, and then it kind of stores where exactly I've cut it and how I've cut it. And now is for the cool part, when we do that soft tissue balancing. So this is going to be a little bit hard because I cut through one of the ligaments here, but we'll pretend that I didn't do that. Go ahead and hit next. Yeah. So now this is, on the top you can see it's called the soft tissue balancing screen. So basically what we do, and I take this off, so this is out of the way, is I have a little tool. Do you have the tensioner? Yep. Let me just see the tensioner real quick. So we've got this little tool here, and it's going to go into the knee joint, and it's got these two separate paddles on either side, and they move independently of each other, and so they can open and close. And then on this side they have a little tension reader, so that when I open that up, if it's getting squeezed, I can see how much tension or pressure they're exerting and pushing, so that I can put this in between and open it up and give equal tension to both sides, so I'm pushing open the same amount on both sides, and then we see what that space is. And now this is giving us kind of crazy numbers, so I'm going to take that out and make it a little bit more realistic numbers. So let's say that that's the position where we're at, and what I would want to make sure is that when I'm squeezing equally, that number on the top right where it's going to say varus or valgus, I'm going to want that within 0 to 1 to maybe 1.5 degrees of neutral, as opposed to really bow-legged where that green line's way off to the side. If I've cut the bone and I put that tensioner in there, and that's what the leg looks like when I've opened it up and put equal tension, that tells me, well, I haven't loosened up those medial ligaments enough, because we need that medial side to open up more. And it's going to let me know when I've done that enough. And so, you know, numbers that look sort of like that, I would say, well, that looks pretty good. I've got a nice rectangular gap. I'm in basically no varus, or maybe 1/2 degree of varus, and we'll accept that. So go ahead and hit store. And then watch the screen. As I flex it up, you're going to see that it's going to start measuring the gap along the back behind the back of the femur and the top of the tibia. And so in the bottom middle of the screen, where it'll say stored values and then medial gap and lateral gap, and it says what that space was when the leg was in extension. And now this is showing what that space is when the leg is in flexion. And I do this with this tensioner again and tension both sides equally, so we know that we've got that equal. And let's say that's what let's give it that. That's what the numbers came up with. And then hit next. And so now the computer is going to say, all right, in order to make that space in extension and that space in flexion rectangular and equal, here's how you need to cut the femur. And the reason it does that on the femur, well, actually, I'll do it on the screen, is because depending on where you cut the femur, proximal or distal, closer to the knee or closer to the hip, if you look at this yellow line right here, watch what happens to this yellow line and this red. That red is where it is suggesting the femoral component is going to go. And so if I do this, you can see I am in essence saying, oh, I want to cut more of that femoral bone off and see where it moves that yellow line and the red femur. But what it also then does is it is changing the extension gap. And so the extension gap is the space in between the bones when the leg is fully straight or extended. And now I've made it in such a way that the extension gap is 14 millimeters and the flexion gap is 10. I'm going to say, well, I don't like that because now those are 4 millimeters apart. So what can I do to make that flexion gap bigger? Well, there are a couple things I can do. I can make the femur smaller. So watch what happens when I make the femur smaller. It made that femur smaller and it made that flexion gap. Now it's 12.5 millimeters. And well, what if I say I switch the angle a little bit? Well, now those gaps are starting to look a little bit better. So those numbers look good. But if I look at, well, what have I really done to this person's femur? These red dots are where their bone used to be, and this red is where their bone is now. And I haven't really recreated their anatomy. So I'm going to kind of say, well, they probably had a pretty good idea where they were before. So I'm going to hit reset. And I'm going to say, well, that looks pretty good. Maybe that lateral femoral condyle was a little bit bigger before, but that position looks good. I look at those gaps. They're nice and balanced. They're both 9.5 millimeters. If I look down here, that's what's called the joint line shift. So if you where the top of the tibia and the bottom of the femur used to be, if I do that, all of a sudden my joint line has now shifted 2 millimeters proximally, because in order to fill that space in, I'm going to need a thicker piece of plastic on the top of the tibia. So now that axis, that fulcrum of where the knee's bending, is going to be in a different spot. So I don't want to do that. I want those numbers to be, a millimeter, maybe 1.5 millimeters. 2 millimeters, in all reality, probably isn't that big of a deal to change that, because that's, only that much. But we want that to be as close as possible. We really want to match their anatomy. But this computer system allows me to tinker with it and change it and make sure that I like exactly where I'm cutting the femur and what size I'm using and how it's flexed or extended or up or down and all those sorts of things before I have made any other cuts on the femur. And that way, once I've cut the femur, I know that it's going to be balanced, and I know when I put those parts in that both of those gaps are going to be rectangular and they're going to be equal in extension and flexion. And to me, I don't see any reason for me to not do it this way, because I've done so many of them and I've gotten so facile with it. And with these guys' help, I would ask Randy, I'd say, all right, make that distal resection 9 instead of 10.5, and Randy will pop it up, and then I'll say, all right, and extend the femur a little bit and make it a size 3, and we just kind of tinker with it and get it to where I want. Now about, a third of the time, what the computer says, I'm just like, oh, yeah, that's good. But very often, I'll tinker with it, and I'll do make some changes to make it how I think it's really going to best fit that patient's anatomy. But that's really, in my mind, the coolest part of the computer, is being able to tinker with that and make that soft tissue balance as good as possible. But any questions?
What about the other extremity in terms of balancing?
Yeah, so the question for the video, what about the other extremity in terms of balancing? It kind of depends on what's going on with the other extremity. So if they both need to be replaced, I'm going to end up making both of them straight. So that X-ray that I showed before where the guy was bow-legged on one side and knock-kneed on the other side, now he's straight and straight. If you only have arthritis on one side and you're a little bit bow-legged on one side but not on the other, it kind of balances you out. If you have arthritis on both knees but only get one of them done, might you be a little bit kind of off balance or off kilter? Maybe, but you know, if that other knee wasn't bothering you, we leave it alone because this is the one that really needs to be straightened out and fixed. Yes?
I had one knee done,
Yes.
but that was a number of years ago. And now, actually, both knees are equally in hurting on that. I can walk and everything, but now if I wanted to have my knees done, how about that one that's already been done and had that metal and whatever? And
Yeah.
then they have to take that out?
So the question is, arthritis in one knee and a painful knee replacement on the other that it sounds like may or may not be worn out. Can both of those get done at the same time? Probably not. So if I do both at the same time, they've got to be both kind of straightforward primary or first time around knees. So what we would do is decide which one was hurting you more, address that one first, get that one fixed and better, and then if the other one was still hurting you, do that other one. But that would be what we call a revision surgery. We've got to take the parts out and put new parts in. Tends to be longer and more blood loss and more risk of complications. So trying to stack that on top of a second surgery at the same sitting, probably pushing things a little bit.
I mean, that answers my question.
Okay, good.
It looks
Yes.
like you're stretching ligaments and tendons and that sort of thing. Is there
Yes.
recovery from that as well? And
Yeah, so the things that really hurt after knee replacement are two things. The first thing is the kneecap. So the kneecap, basically what I do is I cut along the side of the kneecap and then we flip the kneecap almost inside out. And so that really pulls and stretches and even tears a little bit the quadriceps muscle. And that's what tends to hurt the most. The other thing that hurts is that medial side of the knee. More people are bow-legged than knock-kneed, and so stretching out those ligaments on the medial side of the knee is sore, and it can be for a while. But how long it's going to be sore and how much is different for everybody. I've had patients, you know, similar to this gentleman who even after knee replacement, within a couple days are only taking Tylenol. I've had patients who've been on Percocet for 2 months after knee replacement surgery. Everybody's somewhere in between. Any other questions? Yeah.
You said before, is there a time window that you're actually trying to target? And whether this is over 2 hours, then you know.
Yeah.
Into the danger zone.
Yeah. There is not a specific time. So when we're doing knee replacement surgery, we use a tourniquet so that there's no bleeding during the surgery for a couple reasons. One, for visualization, so it's easier to see. The other is for that cement to be able to kind of grab and hold onto the bone. You don't want the little nooks and crannies in the bone to be filled with blood. And so we use that. You don't want the tourniquet to be on for more than about an hour and a half. My average time for a knee replacement, for the time that the tourniquet's up, which is basically from the time that I make the incision until the time the implants are all in. Once they're all in, I let the tourniquet down to start sewing up, is right around 45 minutes. So it's pretty quick. It's pretty quick. Yep.
so the length of time you're in the operating room as a patient is what, about an hour?
So one knee, it's about an hour and a half. 2 knees, it's about 2.5. And that's getting in there, getting off to sleep, getting positioned. You'll have a catheter put in. Most folks get a catheter put in. Getting the leg cleaned and scrubbed and draped and ready. And then the surgery part is about 45 minutes of the initial part of the surgery, and then about 10 minutes to sew you up. So the surgery is a little bit less than an hour until the skin is closed, and then bandages on and waking up and getting transferred back onto your stretcher to get out of the room. So it's about an hour and a half. Yes?
What size is the incision?
Different for everybody. Big enough so that I can see everything I need to see to put it in perfectly. So the question was, what size is the incision? And so the knee is something that I'm making the incision. I'm not worried if it's this big or that big. You know, I'm not making it bigger than it has to be, but I'm going to make it as big as it needs to be so that I can see everything in there and make sure that I'm not leaving bone spurs in there, making sure that I'm not twisting something the wrong way. But usually, to answer your question, I didn't answer your question, usually probably about that long. Anything else? All right, well, thank you for spending your entire evening with me. much longer than advertised, but I appreciate your guys' attention, and if you have any questions, feel free to come on up. Thanks again.